All right, let's go ahead and get started. Welcome on behalf of the Dementia Care Aware team and the California Department of Healthcare Services. Welcome to our monthly webinar. Today's is about adapting the cognitive health assessment for adults experiencing homelessness. And I'm happy to introduce our speaker and provide some introduction. So could you do next slide, please? Great. So my name is Josette Rivera. I am a geriatrician at the University of California, San Francisco, and the education lead of Dementia Care Aware. And I am so happy to introduce today's webinar speaker, Dr. Lanata, who is a behavioral neurologist here at UCSF and also director of the UCSF Memory and Aging Center Community Outreach Program. Next slide, please. We have no financial disclosures. And so to kick us off, I wanted to again introduce or remind us all of the diverse array of offerings through Dementia Care Aware, which includes a warm line. So this is a number that gives support and access to faculty and experts around the cognitive health assessment and dementia screening. And also we have a number of online trainings. There is one ready to go right now about the cognitive health assessment, and others are in development about adapting the cognitive health assessment for diverse patient populations, and many other topics will be coming online. Hopefully they will all be available by September, but they're all being posted on a rolling basis. We also sponsor monthly webinars as well as podcasts. And then in addition, there's interactive case conferences and different types of practice change support. So all of these things you can learn about in more detail on our website, dementiacareaware.org. Next slide, please. So again, you can access all these different types of websites, all these different types of resources on the website, in addition to a 90-minute online training about the cognitive health assessment, for which you can earn free continuing education credits for a variety of professionals. Next slide, please. So just to sort of set the stage and the framework, and for those who haven't taken the core training or attended previous webinars, the entire Dementia Care Aware initiative is about screening for cognitive and functional decline. And we propose to do that through the Cognitive Health Assessment, or the CHA, which is a brief 3-part process. Again, the first part is taking a brief patient history. This might be an annual screening question or noting new signs or symptoms that come up spontaneously. The second part is to use cognitive and functional screening tools. And the ones that we sponsor in our training are validated in primary care settings. They're very quick to use, and they're free, and they're easy to score. So we were very selective in which tools we put forth. And then finally, part 3 is about documenting a care partner, whether that's a formal or informal caregiver and or a healthcare agent. So again, you can access the training on how to do each of these parts in more depth online at our website. And we propose doing this partly because it allows you to start a brain health plan at the earliest detection of symptoms before you even have a diagnosis. Before you don't need to get a diagnosis. This is just to get you started on the way towards a diagnosis. And we go through that in depth, and we will have a next steps module on what to do after a positive screening. That's going to be coming live in the next couple of months. Next slide, please. And so now to set the stage and our learning objectives, I'm going to turn it over to Dr. Lanata. Welcome and thank you.
Thank you. Thanks for having me. Thanks everyone for being here. These are the objectives for today. We're going to talk a little bit about the history of homelessness in the U.S., the magnitude of homelessness in the U.S., in California in comparison to other states in our country, learn a little bit about brain health and homelessness, and that'll set the stage to focus more on how do we conduct a cognitive health assessment or evaluation in people that are experiencing homelessness, considering the barriers that are commonly encountered. Okay, so first let's delve a little bit into the homelessness, the history of homelessness in our country. And I think experts, historians, this is going to be very brief. Historians date this back to the Industrial Revolution, actually. Back in the 1850s, 1840s, 1850s is the first era of homelessness. Then there's another one in the 1880s, 1940s, and then our current era of homelessness, according to historians, began around the 1980s, and we're still in the same era. And we're going to talk a little bit about key evolutionary factors here. So what was going on in the 1850s, this is like post-industrial revolution, big shift in the way people work. Factory work was growing and was very prominent during this time. And you saw the migration of people from rural areas, working mostly in the farms, migrating to the cities or urban centers to take advantage of these factory work that was more reliable and was conducive to a more stable income. And these people were labeled as tramps. Mostly they were white people in the United States, people that would leave their homes, leave their families, migrate by themselves to urban centers, just for pure economic reasons, basically trying to find jobs. And they were not looked upon positively by society in cities, similar to what's happening now, I would say, in most cities. But it was a different driver of homelessness. Then in the 1880s, the term tramp slowly faded away, and in its place emerged the idea of a hobo, who was a person that would migrate between urban centers or along the rail lines, basically railroads, looking for temporary jobs, and that way supporting themselves and also their families back in the rural areas. And so I think that the main point is that these two initial eras of homelessness were driven more by extrinsic factors, meaning there's a high demand for jobs and a low supply of these jobs early on, people trying to find those jobs and sort of competing for these jobs in a setting where there wasn't enough housing yet to house them. This began to change in the 1940s. This is post-war period, where we start to see the emergence of what I'm calling, for the purpose of this talk, more intrinsic drivers of homelessness, meaning, and mostly I'm going to stick to the health-related factors. These were, for example, people that were coming from war with permanent injuries, disabilities, unable to take on jobs, and also finding, upon coming back, that there wasn't enough of a housing supply to house them. This became the one prominent driver of homelessness during this time period. Basically, maybe the first time where physical disability and illness more broadly became a prominent driver to homelessness, what I'm labeling an intrinsic factor. Then in the 1980s began our current era of homelessness. And here we see, according to historians, a synergy of factors. Number one, the progressive deinstitutionalization of mentally ill persons that were traditionally, or not traditionally, but for a long time housed within psychiatric institutions and were deinstitutionalized, oftentimes for very good reasons, obviously. But just to give you a context, back in 1955 in California, there were about 37,000 psychiatric beds. And by 1983, that had dropped to 2,500. The idea was that as persons move from institutions into the community, there would be a support system in communities that would be able to house persons and support them. But that really never materialized as it was idealized. And that was a big contributor to the homelessness crisis that began to emerge in the 80s. Together with that, we had the HIV/AIDS epidemic, another intrinsic health-related factor that pushed many people towards homelessness. And with that, also economic factors. There's a huge recession, the worst since the Great Depression, according to some historians. And this persistent lack in supply of housing, right, that had began decades before. So you have a combination of factors that is leading to a new an emergence of a new homelessness crisis, where it was not only, going back to the hobos, not only white adults that were looking for a job, but and older adults or midlife adults, but now a combination of factors that was leading to people becoming homeless younger, even children becoming homeless, people that were ill, etc. And that's where we are still right now. Now let's talk a little bit about homelessness in California and in the US. First, let's define homelessness. This is how the Department of Housing and Urban Development defines homelessness. Basically a person whose primary nighttime residence is a public or private place that is not meant for human habitation, or a person that is living in a publicly or privately operated shelter. That's essentially it. The other conditions are also related to this definition of homelessness. So if we think of homelessness in California, and this is data from I'm going to share some data from 2020 and also data from San Francisco, just to give you a sense of the homelessness situation in our city here. And then we're going to talk about some challenges surrounding older adults. So every year since 2005, the HUD has conducted this point in time count, where they literally count every person that meets category 1 homelessness in a city, in every city or every state in the US, I should say. So if you look at the data here, this is 2020 data. In California, 161,000 people were experiencing homelessness on a single night in January in 2020. You can see that the East and West Coast have the highest proportion or highest number of people. You may be tempted, and that's for California alone, that's 27, almost 28% of the entire population of homeless people in the country are living in California. You may be tempted to think that that's just related to the fact that California is the most populous state, but I don't think that's the only factor here. There's others that I'm going to highlight in a moment. Just to compare to the East Coast, numbers are also pretty high in the Northeast, as we know, but compare this to what's happening in other populous states down in Texas, in California. Texas has only 4.7% of the homeless population of 2020. Florida also 4.7, 4.6. So keep that in mind as we move forward. So 2020 marked a net increase of homelessness for 4 consecutive years. 2020, for the first time, found more unsheltered than sheltered homeless persons. This is a big deal because unsheltered homeless people tend to have the greatest, the most marked health consequences of homelessness, as we're going to talk about in a moment. 39% of these persons were found to be living in places not suitable for human habitation. Black African Americans, and Latino Hispanic Americans are highly overrepresented in the homelessness population nationally. And unfortunately, the HUD does not give us data divided by age beyond age 25. But this statistic is also important. I'm going to come back to it later. 88% were adults older than 25. These are the rates of people experiencing homelessness of unsheltered homelessness per state. Highest rate in California. So we're leading that count, unfortunately, of 161 homeless people, 161,000, 113,000 were unsheltered compared to other states. You can see the numbers here. In 2020, more than half of all unsheltered homeless persons in the country lived in California. And this is the next figure goes back to the map I was showing you earlier. This is 9 times more people than the next state on that list, which is Texas. So there are other factors, let's just say that are making our state, let's say, have a higher risk of homelessness. These are some data around persons that experience chronic homelessness. This is a person with a disability that has been continuously homeless for 1 year or more, or has experienced at least 4 episodes of homelessness in the last 3 years, where the combined length of time is at least 12 months. So in 2020, California accounted for 40% of chronic homelessness in the country, and we exceeded the national average of persons experiencing chronic homelessness per 10,000 people. So 77 people versus 21, which is the national average. This is another big factor that we need to be aware of in terms of not only its impact on general health, but on brain health and therefore cognitive health, as we're going to talk about in a moment. San Francisco, as you probably all know, is an epicenter of homelessness in our state. Back in 2018, there was a UN representative that came to just monitor the state of homelessness in different parts of the country. And you can look for her testimonies, but she was really, the way she described homelessness, and keep in mind that this person had visited other encampments throughout the world, including in low-income countries in cities like Mumbai, Mexico City, Delhi, Santiago de Chile, and had not found conditions like the ones that she found here. So this is obviously a big deal for us. This is another way of showing the impact and the cruelty, I would say, of the homelessness situation in our city. This is the human waste complaints in San Francisco alone, and how they've been progressively increasing over the years. A big failure on our part as individuals and as a city, I would say. San Francisco has a unique problem. Per 100,000 residents in the city, 490 are homeless, compared to 420 in LA, 250 in Seattle, and 45 in New York City. Some critics believe that this is in part the result of the fact that California as a whole, and San Francisco specifically, has not invested enough in shelters. And some people believe that this is a result of the fact that, of what I was telling you earlier, that there's been a push to deinstitutionalize people with mental illness, to the extent that shelters feel a little bit too close to institutions. That's not me, that's what I've read. And maybe that's part of the driving factor. But that, in the end, hurts the people that are experiencing homelessness, because they tend to be unsheltered, they tend to be chronically homeless and have more health issues, including brain health issues. San Francisco goes beyond the point-in-time counts. They do their own counts to include other places. And this is the data that I collected up to 2019. I don't have data after COVID. I want to wait until the dust settles a little bit to look at what's happened after COVID. Some experts in San Francisco estimate that the number is much higher, actually, close to 10,000. And you can see that the proportion of unsheltered people is rising, in part because of the factors I mentioned earlier. I thought this was interesting too. These are the total number of people experiencing homelessness per district, shown on the left. Each district has its own number, and these are the number of people approximately in each district. And to me, this was very significant, because on the right, you see a map that we created here, where we took data that the Department of Public Health has for the city of San Francisco across many different variables that predict vulnerability, health vulnerability, access to parks, for example, accidents, traffic accidents, pollution, economic diversity of business establishments, things like that. We put all that data together to create this vulnerability map that you see on the right, with the red areas being the most vulnerable. Not surprisingly, because of historical factors that we're all aware of, the eastern neighborhoods of San Francisco are the ones that are mostly populated by people of color, and those are the most vulnerable. These neighborhoods are strongly Asian American as well, the western neighborhoods here. And those are the neighborhoods that have the highest representation of homelessness. Again, highlighting that it's the major markers here are socioeconomic drivers, actually, not markers of homelessness. This is a study of self-perceived primary drivers of homelessness in San Francisco, data collected by the city. You can see that the primary drivers are socioeconomic or economic, losing a job. Second would be substance use, eviction, and more personal or interpersonal issues. Mental health was not at the top of that list, contrary to what most people think, or not most, many people. On that study, 63% of respondents reported that the primary reason why they couldn't obtain permanent housing was cost of rent, not surprisingly. for those of us who live here. 19% reported that the main reason why they couldn't move towards permanent housing was due to the housing process being too difficult. To me, as a neurologist, this is very enlightening, because it highlights the possibility of a cognitive disorder, right? So if you, and this has been documented by researchers and people that are trying to help homeless persons, that it's very difficult for them to go through all the paperwork and all the steps to try to help themselves out of homelessness. And so that maybe highlights an executive dysfunction or problems with planning, cognitive tasks, cognitive abilities. So I'm going to return to the issue of aging in a little bit, but also take a look at this graph that shows how different age groups, the representation of different age groups throughout the years in terms of homelessness in San Francisco. We don't have a breakdown of the 61 and older, but I'll tell you that this age group of the people 45 and older actually is has been increasing over the past few years, meaning that for the first time, we're seeing that people are experiencing homelessness for the first time after the age of 45, compared to other time periods where that was rare. So that also catch my attention, and we should be concerned about. When it comes to brain health. I just want to show this study. This study was led by some researchers in Berkeley, and they were looking at, what are the factors driving. So let's see. So because the primary drivers of homelessness are economic and lack of housing availability, then the natural question is, okay, why can't we have more housing built? So they looked at all the barriers, right? So in a liberal society, in a traditional, classical liberal society, there's economic freedoms and social freedoms within a legal framework. And the idea is that if you own property, you should have the freedom to develop it as you wish within a legal framework. Well, that's not happening in California, because on top of that legal framework that is written and exists, there are all kinds of organizations and groups that are putting barriers to development. So what this graph shows is that in San Francisco, for example, if you want to build a unit, if you want to say, sell your home or a group of homes and sell them to a developer so they can build a tall building with many units, it will take a long time, 30 months, 35 months, to get approval, if it gets approval. So these are the time it took for the successful projects to get developed. So this is the core of the problem. And I bring this up because this is a health issue. It's a health issue. It's not just a socioeconomic issue. It's a health issue for us. Okay, so now let's enter into the issue of age. So what researchers are seeing is that there is basically, as I said before, for the first time, we're seeing people entering homelessness in old age. And what we're seeing is a cohort effect. So people that were born on the latter half of the post-war baby boom period, so 1955 to 1965, carry with them, let's say, a socioeconomic burden that puts them at risk of developing homelessness at different periods of their life, later in life. And this is a reflection of the fact that when these people came into the labor market, there was an excess supply of workers and not enough opportunities. And also they entered the workforce at a time where housing supply was low. So you kind of carry this throughout your life, this struggle, which puts you at risk of experiencing homelessness after a relatively minor economic challenge, And this was also supported by this study in 2015, where they found that about 45% of adults age 65 and older were economically vulnerable, with incomes below 200% of the poverty threshold of 2013. This totally reflects what I see here. I see many older adults in the community clinics that we run, that we have here in San Francisco, that I've developed a habit of asking, every time I meet an older adult in the community, how do you make ends meet economically? And the vast majority of the people that I meet here are living month to month. On top of that, based on data, I think from 2016 or 17, up to a third of people, or 30% of older adult San Franciscans, live by themselves. So they're alone. And so their vulnerability is super high, which I think can easily, obviously, can put them at risk of becoming homeless if something happens, an extra bill or some accident, etc. So then, using this data, these researchers try to project, what are going to be the trends in the future. So there's going to be up to a threefold increase in homelessness in metropolitan areas in our country among older adults. That's the projection based on all these factors that I've mentioned. So this has prompted many researchers, including Margot Kuchel here in UCSF and others, to try to look at what are the health consequences of experiencing homelessness when you're an older adult. So this is one of these studies, very influential study, where they interviewed and examined a bunch of people that were homeless, that had entered homelessness as older adults. And they found that many of them had impairments in ADLs and IADLs, 88% of them, pertinent to our work, where we know that IADLs is a requirement for a diagnosis of dementia. Mental health concerns, highly prevalent, smoking, hypertension, illicit recreational drug use, mobility impairments, cognitive concerns, etc. And this was very telling. The authors concluded that despite a median age of 58 years, participants had rates of geriatric conditions similar or higher than adults in the general population who were housed, with a median age of nearly 80. So the idea that the experience of homelessness can bring aging faster, can be a risk factor for accelerated aging, let's say. And that's also obviously of concern to anybody that is evaluating people with cognitive impairment and thinking about brain health in homeless persons. And that's the next topic. Let's delve into homelessness the issue of brain health and homelessness. This is how I frame my thinking around dementia. So we have these brain health outcomes, the neurodegenerative and cerebrovascular diseases, or vascular diseases that lead to dementia, that cause dementia. Research conducted in house persons, so in mostly urban areas around the world, are highlighting these as the main risk factors for developing late life dementia. So notice the overlap between these risk factors and the factors that are highly prevalent in younger people that are experiencing homelessness. So there's a link there. And just as we know that diabetes is linked to behavioral factors like the diet that you eat, these factors are intimately connected to more upstream factors, social and environmental factors, some of which I'm highlighting here. So this is where I feel like this is how we should frame the issue of brain health and homelessness, because people that are experiencing homelessness not only carry a high burden of these factors, but they are constantly exposed to these upstream factors, further deteriorating their brain health. And that's the main issue. And so going back to the study I showed you earlier, I want to put it side to side to this study that was released by the Lancet Commission in 2020, where they did like meta-analysis basically of all the documented risk factors for late life dementia, regardless of cause. So this includes Alzheimer's, vascular, whatever other cause of dementia. And they identified these key risk factors divided across different age periods. And basically here they are: midlife, late life, it's mostly smoking, depression, social isolation, physical inactivity, air pollution, and diabetes. And the prediction is that if we can do population-based interventions to address these modifiable risk factors, we could potentially prevent up to 40% of cases of dementia at a population level. I would argue that these factors are even more important to address in people that are experiencing chronic homelessness. So with that, going back to what we've said before, the overarching goal of the CHA is to help us identify people that have cognitive impairment. And the way I think about this is that a person with Alzheimer's disease or another neurodegenerative disease like Lewy body disease or frontotemporal dementia, now we understand that they go through a long illness that has many stages, including asymptomatic stages. And then they move on to develop subjective cognitive decline, mild cognitive impairment, and dementia. And the CHA is helping us identify these two stages, MCI and dementia. The earlier we can identify a person with a neurocognitive disorder, the better for planning purposes and other purposes. And also because, as you may have heard, there are disease-modifying therapies that are coming out for Alzheimer's disease. A lot of controversy about them. I understand that, but that's where the field is going to. So we're going to see more of that down the road. Oh, and just a note that MCI is now, for a long time now, has been recognized as mild neurocognitive disorder by the DSM-5, and dementia is synonymous with major neurocognitive disorder. This is how they parse out the criteria to make this diagnosis as a clinician. Basically, someone with mild neurocognitive disorder has evidence of cognitive decline per self-report or someone else, including a clinician. The cognitive decline is substantiated or supported by cognitive testing. You can choose whatever cognitive testing you want to use, and we're going to help you identify those. Importantly, for MCI or mild neurocognitive disorder, the cognitive decline is not interfering with ADLs. Okay, they can have some difficulty, but they're able to compensate. That's essentially, in a nutshell, what MCI or mild neurocognitive disorder means. And of course, you have to make sure that the cognitive decline that you're seeing in your patient is not better explained by delirium or a psychiatric disorder. Contrast that with major neurocognitive disorder or dementia. The two first conditions need to be met. The only difference is that now you have a patient that cannot live independently anymore. So it does interfere with ADLs. Their cognitive disorders does interfere with ADLs. I think the DSM-5 does a brilliant job at helping us say, okay, first I'm going to decide if my patient has mild neurocognitive disorder or major neurocognitive disorder. I'm not going to even think of causes or etiology. That's like a next step, and that's where they bring the subtypes. So now you can enter like a billing where you say, my patient has major neurocognitive disorder due to Alzheimer's disease, or due to HIV, or due to Lewy body disease, or you can say, I don't know, unspecified, or you can say, I think there's more than one disease process going on. So that's important to keep in mind. Okay, so now going back to homelessness. So we're trying to, so I'll speak just for myself. For a few years now, I've been volunteering I've been working in a clinic here in San Francisco that serves almost all of their patients are experiencing homelessness. And I've been trying to bring this framework into this clinic, and it's been challenging, but it's doable, and there's ways to do this, and that's what I want to hone in on now. Now, just to be upfront, there's a lot of challenges here, obviously. I'll say that obviously the homeless population, people that are experiencing homelessness, chronic homelessness, extremely diverse population across many measures, race, language, how long they've been homeless, what type of life they live, and that has to play into how you evaluate them. But up front, we have a big problem, which is that, as this study from 2019 highlights, there aren't good studies that really have validated, even regionally, cognitive assessment for people that are experiencing homelessness. And I think this is important, an important gap, because in my opinion, this should be a regional approach. The homelessness in the East Coast, West Coast, probably very different, and we need to find a way of evaluating cognition in these persons. But this is part of a bigger challenge that I think we have, where thinking I'm originally from Peru, and when I evaluate someone here that speaks Spanish, I don't know what norms to use, because oftentimes it's someone from a rural community in Central America, and we're using like norms from Mexico, and that doesn't make any sense. So we're all kind of doing the best we can. It's a challenge that we have, and that challenge applies to picking like screening tools for homeless persons. So what I would say is probably, so what I will say is, MOCA is, for instance, decent for if you're meeting someone who is homeless that has finished high school or beyond. For people that have low literacy, I would choose something else, maybe the RUDAS, RUDAS. That would be a reasonable instrument, but you're not going to find a perfect instrument. You just have to stick to one that you feel comfortable using. I would divide it in those groups: people that have gone through school, people that haven't, and then learn to use it, feel comfortable using the instrument and get used to it so that you know what it means to you internally. Does that make sense? So, and then you can use that as a foundation with which you can monitor your patient over time. That becomes their baseline. That's a very important point. I think we have a similar challenge when evaluating homeless persons, and when it comes to picking like a brief instrument that we can use to evaluate their level of independence, their ADLs, because there's nothing that I'm aware of. There's no systematic review on this either, and so this is, for instance, the BIFS. The Brief Instrumental Functioning Scale that was validated in 2001 to be applied to homeless persons. I think, pretty sure this is what Dr. Margaret Kuschel uses here in her studies. But as you can see, it's pretty basic. And the challenge obviously here is that most of the ADL instruments are designed to assess activities of daily living in people that are housed. So they'll ask about, can you write a check, and can you balance your finances, and can you operate like some, the microwave and things like that. But none of that applies to people that are homeless, chronically homeless, especially, or living in the streets or in shelters. So then the challenge is, how do you probe ADLs in a person that is not housed? So this is one approach. You can read these questions and quickly come up with issues with them, but I put them out here because this is among the better ones, and it's still challenging. So here I would say that when you're assessing functional abilities, I would take what I do is I take a similar approach as I told you for the cognitive screen. Try to I modify my own assessment of ADL's instrument to sort of meet the life of the person that I'm meeting, and I use that as a baseline. And then I try to compare with future visits. But this is very challenging. I became interested in this topic from a research perspective too, when I met this person who had been having cognitive issues 7 years prior to presentation, initially with some changes in personality, demeanor, a lot of mental rigidity, and family was knowing it was very difficult to engage in conversation with this person. Then they began to notice a very clear pattern of impairment in language function, not speech, but language. So that means that there's clarity of speech, but the words, the actual content of language was changing. Difficulty coming up with names, recognizing the meaning of words, and this was making their conversations very difficult at home. Over time, personality became even more difficult, until finally one of the family members decided to literally kick this person out of the house after an altercation. And that's how this person ended up in the hospital, initially diagnosed as having a schizoaffective disorder. So basically contextualized as a mental disorder. And then we were consulted to see this person, and to us, it felt like this person had primary progressive aphasia, which is a type of frontotemporal dementia. And what you're seeing here is that there's a bit more generous CSF space, let's say, in the frontal lobes dorsally. And if you compare the spaces here compared to the right, there's more atrophy of the left temporal lobe. And she basically had the clinical presentation of somebody with primary progressive aphasia semantic variant. These patients are known to have a lot of changes in personality, psychiatric changes, which clearly put her or him or they at risk of developing homelessness. And so this really ignited our curiosity about, okay, let's look at our patient population, or more specifically, our research participant population. So we looked at all of our research participants that have come to the Memory and Aging Center with different neurodegenerative diseases between 2004 and 2018. We produce detailed research visit summaries on our participants that we share with their families, the participant, or their primary care doctors. And we found that 13 of our participants had experienced or had some relationship with homelessness, which on first view doesn't sound like a big number, but it is a higher proportion than the national proportion of homelessness, which is 0.17%. So there's a overrepresentation of homelessness in even our research cohort. And mind you that we attract research participants that are not economically vulnerable generally, or highly vulnerable, and are very well supported by their families, because that's one of the requirements. You need to have a study partner to come. 5 participants experienced homelessness while symptomatic of a neurodegenerative disease, but before receiving a formal diagnosis. 8 were had I don't know how to word this, but they had a propensity towards homelessness after being diagnosed, meaning that they would either want to hang around, be homeless, around homeless people, or be outside. And not basically, this is beyond wandering. I don't know how to explain it, but they were basically spending a lot of time outside, looking for food inside trash cans, doing this type of behavior. Most of these participants had frontotemporal dementia. And this last point is important. I think it circles back to what I was saying before, that the majority of these participants had become homeless in the setting of economical issues happening in the part, or socioeconomic issues, fights, arguments, or a downturn in their economics. I'll just want to highlight a few examples. So this is a person with semantic variant of PPA in our center that had definite frontotemporal dementia, because this person made it to autopsy and we diagnosed it that way. Diagnosed somewhere between age 55 and 57, and they were homeless. This was before diagnosis, I think. Yes. So, oops. And just to give you a flavor of the issue here, so that participant became homeless shortly after becoming symptomatic of their illness. So family began to notice the cognitive and personality changes, which got this person into problems with the law. They were admitted to a mental health facility, and they received the diagnosis of adult-onset schizophrenia. And at the hospital later, this person was observed to be looking through trash bins, taking food, getting cigarettes from other residents, removing his or her clothes, going to the resident beds, and wandering aimlessly. This person did not have a primary psychiatric disorder. This was a primary dementing disorder. This is a person with definite BVFTD also. And based on brain autopsies, there's no room here for doubt. And also a lot of changes in personality, which you typically see in frontotemporal dementia. And this was interesting because this person was one that was always around homeless people. During their illness, this person wanted to be around homeless people, bringing them food, eating with them, just being around them. So we see basically dramatic changes in brain health that lead to dramatic changes in personality and behavior, including homelessness, in our research center. So then we took this a step further, and this is where I can tell you that it is possible to do a complete neurocognitive examination, including what we're proposing at DHA, in persons that are experiencing homelessness. You can take a good history. If you're strategic about it, you can get a reasonable cognitive exam, and you can also assess functional abilities with help from the staff. Staff that know these persons. So we looked at 25 people, and basically we found that all of them had some form of cognitive complaint, either memory, visual spatial, language, executive, or emotional changes as well. Or you can think of it as the DSM-5 does, The social cognition domain was also affected. We found many of them had focal neurological deficits on exam. None of these participants met our criteria for being neurocognitively normal or healthy. And most of them, 84% of them, met criteria for mild neurocognitive disorder or major, based on the criteria that I showed you before. And 17 of them actually met clinical criteria for possible BVFTD or frontotemporal dementia, possible Alzheimer's disease, coupled with that met clinical criteria for Lewy body disease. And 7 had MCI non-specific. They were basically having signs of impairment. We could substantiate it clearly on testing, but they were seemingly functionally independent still. For this study, we used a TAPCAT. This is another brief cognitive test that is available to you. It was developed by UCSF, and you can reach out to me or directly to Dr. Posin, who leads that study. So maybe we're going to start to end with a few other comments and bring in this case to highlight the barriers and how to mitigate them. So this is a Spanish-speaking person originally from a rural town in Central America, no formal education, has been living in the US for over 40 years and has been homeless for a few months, living in different shelters. So that's a limiting factor because that means that there is probably not someone that has been observing this person consistently. So very hard to get a sense of functional abilities over time or even cognition over time, perceived cognition. 30 plus years of intermittent heavy alcohol use. So that makes you wonder, okay, is this person someone that I'm going to be able to engage with? And most recent job was as a taxi driver. And then to add complexity to this, like he's basically here alone. There's only one family member that doesn't live locally. Family history notable for a mom, his mom or her mom with a neurocognitive disorder late in life, never formally evaluated, got a 14 out of 30 on the MOCA, mostly for frontal deficits. And the neurological exam did not find any cerebellar signs as pertinent. And then we took an MRI of this person's brain and found that there is some atrophy of the frontal and parietal lobes cortically, but no changes to cerebellar volume. And no cerebrovascular disease. So the way this person came to me was, we think this is alcoholism, but we want you to take a look. And I came back with, I don't think this is alcoholism because there's atrophy that doesn't follow the expected atrophy pattern where primarily the cerebellum is involved. He doesn't have any cerebellar signs on exam. He's walking fine. There's no dysmetria. The MOCA is giving me signs of sort of a focal pattern of impairments affecting the frontal parietal, frontal parietal networks, which I'm also seeing as mildly atrophic on MRI. So I think there's maybe a neurodegenerative disease going on. This person was referred to our clinic, and we're in the process of getting biomarkers for Alzheimer's disease, which is the more likely scenario. So the challenges in general, as we've talked about before, are in another webinar was, the issue of how do you measure cognition in somebody that has psychiatric illness and is in an acute phase of psychiatric illness. We talked about how, there's always the opportunity to try to find a moment where they're not floridly psychotic, for example, because these disorders wax and wane. Same thing with substance abuse in the persons that I've been evaluating. There are many times where I start evaluating a patient, they smell like alcohol or they look like they're obviously intoxicated. I stop and I try to just do it another time. Chronic illness can be an impediment, especially chronic pain, which can get in the way of getting a good cognitive assessment. Same with musculoskeletal issues. Vision and hearing loss, we've talked about before. The issue of social isolation is a big one. Most of the persons that I've evaluated here that are homeless are very isolated. They don't have any family member nearby, or if they have family members, they don't want you to talk to them. And So that's where I rely a lot on the providers that have been supporting this person, either in the shelter or in the clinics, staff, people that know them, that can paint a picture of functional decline over time and cognitive changes over time. So it becomes a different approach to getting the history and getting an assessment, a sense of their change over time. Well, that's all I have. Thank you for your attention.
Thank you, Dr. Lanata. I see only one question so far, and if there are more, please feel free to drop them in the chat. The question is, do you recommend MRI for everyone, or is CT scan sufficient? And I'm sure you need some qualifiers for that, but that was the question, MRI versus CT scan.
Man, I'm pretty straightforward with this. I think, let me put it this way. People get MRIs when they show up to an ER or a clinic for a headache that oftentimes feels like migraine, and they just go ahead and order an MRI. And it's mind-boggling to me why somebody with a change in cognition, which is central to everything who we are, would not get an MRI of the brain, especially if they're homeless. I think it's super useful. It's more useful than a CT scan for sure. Why? Because because you can, if read by someone knowledgeable, you can get a sense of atrophy patterns. You can get a sense of cerebrovascular disease burden, which is a very common contributor to cognitive impairment in homeless populations, in my opinion, homeless persons, for all the reasons that I mentioned, all the exposures that they have, TBI, cardiovascular disease factors out of control, etc. And that oftentimes is the primary driver of their neurocognitive illness. Even in the setting of psychiatric illness or substance abuse, if you see a high cerebrovascular disease burden on an MRI, you have something going basically to explain cognitive impairment in that person. And that may help also prognosticate what the future may look like, because we know that people that have a high cerebrovascular disease burden in mid-late life, that's not going to get better. It's going to get worse. Despite how good you are at treating their psychiatric illness or controlling their substance use. So yes, I would be very, if you have ready access to getting MRI, I would just go for it.
Great, thank you. Any other questions? Maybe we'll advance to the next slide. Oh, go ahead.
No, you go.
Let's see, there's one more here. Okay, thank you. Thank you so much. So I just wanted to alert you again to the warm line as you think about implementing cognitive health assessments in your practice or need any kind of practice support, such as these questions here. Feel free to call our warm line. You can also scan the QR code to submit questions or visit the website. Next slide, please. Also, to claim continuing education credit for attending this webinar, please go through these steps. We provide CME and CAMFT credits. Let's see here, upon completing evaluation. Yeah, okay. Yeah, so you can also scan a QR code, enter your name, and claim 1 credit for the webinar. And there are also links in the chat. Thank you, Rita, for putting those in for easy access. And I see we've got a couple minutes left, and I see one more question. Dr. Lanata, what would be the treatment recommendations for someone with one of these complex dementias who is homeless? Yeah,
I think they would be the same. In my opinion, they should be the same as any other person who has a neurocognitive disorder, but to start there, right? But that we're not there. I mean, it is a huge I'll just speak for what's happening in San Francisco based on my experience, my limited experience here, which is that there's a big barrier where, these persons it's very difficult to connect them to the services they need to support them in this journey, let's say, of going through a neurodegenerative disorder. And that's extremely challenging. So you need social work support, case management, and I think we would all agree that those are all in short supply. And then I just feel like this is an overarching challenge on top of everything else that a chronically homeless person needs to deal with. And I wish I had solutions. I don't, but it's something that we can all work on, I think.
Thank you. Anything else?
No, thank you.
It looks like I don't see any more questions. Oh, wait, maybe one more here. Sorry. From Dr. Chodos, I don't know if you can see that. Any tips for primary care providers of PEH with cognitive impairment or dementia in terms of supporting these folks while on the street or unhoused?
In PEH? What's that? I didn't get that.
Let's see here.
PEH? What's that?
I'm not sure.
I don't know.
Yeah. Oh, persons experiencing homelessness.
So what is the question again?
Any tips for primary care providers on supporting persons experiencing homelessness while they're unhoused?
Wow. I don't know. Maybe you just said have any thoughts there as a primary care provider?
No, I mean,
I come in as a specialist, and
yeah.
I basically do my best at helping the primary care provider understand what could be going on with the patient they're meeting, aside from everything else. But then I'm very limited in what I can do after that, unless I refer them back to my clinic, which is for obvious reasons very challenging, where they can connect with social work and other support.
Mm-hmm. Mm-hmm. Yeah, I mean, I am a primary care provider, but the nature of my practice is house calls. So one of the criteria is they have to be housed in San Francisco. So I don't have direct experience with it.
There's a question about disease-modifying therapies and how do we improve access? Wow, yeah, this is what I'm very whenever I can, I say this because I think we're so behind the ball in general. I include my community of specialists, or like whatever you want to call them, behavior neurologists, and also primary care, and as a society in general, in our conception of these diseases, right? And recognizing that if you're diagnosing people with dementia, it's too late. It's like diagnosing somebody with a pulmonary disease when they're ventilated in the ICU. They're like, oh yeah, they have a pulmonary disease. We have to shift things and diagnose people early when symptoms are mild cognitive impairment. And why is this important? Because all the disease-modifying therapies that are coming down the road, that's where they're going to be useful. They're not going to be useful when people have dementia, when they've reached dementia level of impairment, when they have clear impairments in ADLs, significant cognitive impairment on cognitive testing, and atrophy on MRI. They're not going to benefit from these drugs. So before we even think of how are they going to benefit homeless persons, we got to develop a framework that shifts our mindset to being very open about identifying people with MCI, whether or not you think they have AD, just identifying them. And that hasn't happened yet. And that's a huge challenge. And the other question is, are there any counties or states that can be used as a model for best practices in treating dementia in homelessness, or let's say treating people with cognitive impairment more broadly? Man, Josette, do you have any ideas there? I don't know of a model.
I don't know of anyone to hold up as a model now,
No.
unfortunately.
I'll say that within my field of neurology, I don't know of any colleagues that are invested in this population.
Hmm.
But I haven't scoured the literature either, so I'm not sure.
Mhm, mhm. Well, I recognize it's time, and I want to thank you, Dr. Lanata, for your time and for this wonderful presentation. Again, I invite everyone to submit for CE credit if that's relevant to you, and to join us for our, I'm sorry, I was saying this was the July webinar, it's June. Join us for the July webinar next month. Thank you so much. Thanks to
Thank
everyone
you.
for coming.